There's one thing that I want to emphasize. No matter what your gynecologist says, you do not need a hysterectomy for benign fibroids. Period, end. UFE is likely going to help you.
Hey everyone, welcome to the Fit With Fallon show. Today I have a very special guest on my podcast. He is Dr. Lipman. He is an interventional radiologist. You may not know what that is, but he's going to help explain. He is also the founder and medical director at the Atlanta Fibroid Center. So today we will be talking all about fibroids. It's something many of us women struggle with, even myself, and I didn't even know I was struggling with it for so long until I started having certain symptoms and we started looking deeper. But welcome to the show, Dr. Lipman. Thank you for having and coming on my show. How are you?
Great. Thanks for having me. This is fun.
Yeah, I have so many questions. My Instagram is blowing up with a bunch of girls who have questions for you too. So first, I would like to know what made you get into, I guess, this form of medicine. You're an interventional radiologist, which a lot of people don't even know what that is. So can you tell us more about that?
Oh, sure. Interventional radiology is a specialty within radiology, diagnostic radiology. Diagnostic radiologists might read x-rays or read radiology studies, but an interventional radiologist actually takes care of patients and treats the very conditions that we can diagnose with radiology. So what I do as an interventional radiologist, and my particular area of expertise, is I treat women that are suffering with uterine fibroids. And instead of them undergoing surgery, let's say a hysterectomy or a myomectomy, and we can talk about what those are the surgical answers for fibroids. I do a procedure called Uterine Fibroid Embolization, UFE. It's also called uterine artery embolization. It's the same procedure. Mm-hmm. It's completely non-surgical, outpatient. Patients come into our center in the morning. It takes me about 30 to 40 minutes to perform. They leave the same day with a Band-Aid. That's it. And their uterus. So yes. It's a tremendous procedure.
Let's talk more about that because it is shocking. I didn't know until I was going through my own journey that so many doctors are automatically reverting to, oh, you have fibroids, we got to take out your uterus. And as being a newly married woman who wants to have kids one day, I find that so shocking. And I'm so happy that I did more research because that is something that would have, drastically changed my life in a way that I wouldn't have wanted to. So how do women know, that they have other options, or is there a point where you do have to take your uterus out?
Well, it brings up a number of these issues. First off, it's really important for a woman or anybody, that matter, to be their own health advocate. To really, no matter what the conditions, we're talking fibroids today, but we could be talking about any medical condition. The patient really needs to take responsibility and become their own health advocate and really, dig deep and research the condition. So for fibroids, I would really look up about fibroids, what they are, what kind of symptoms, what questions do I need to ask the doctor? What are the typical treatment options? What do I need to know about each of these things? Armed with questions for your doctor. Fibroids are very common. It's the most common pelvic tumor in women, and it's particularly common in African-American women. 80% of adult African-American women have these benign fibroids. They're not cancerous. They don't turn into cancer. They're benign, but they can cause absolutely miserable symptoms, particularly heavy bleeding. It's the number one reason why women have heavy periods, and we can talk about what constitutes a heavy period because some women don't realize they've just been doing it for so long, they think it's normal. It's not.
Yep.
They cause pain, they cause urinary frequency, they cause painful intercourse, they cause constipation. There's 3 locations for fibroids, and their location determines what symptoms are going to either predominate or be there entirely. The 3 types of fibroids are submucosal fibroids, which are located right underneath the lining of the uterus. Those cause the heavy periods. The ones that are deeper in the muscle, kind of in the middle of the uterus, most of the uterus is muscular. they're the most common. They're called intramural. And then the ones on the outer part of the uterus, those are right underneath the outer covering. Those are called subserosal fibroids. The subserosal grow away from the uterus, and they just press on whatever's next to them. And these tumors are hard and firm. They're like rocks. And that's how they cause the symptoms, by pressing on things. So, for instance, a woman might feel a fibroid in the front of her uterus. Well, the uterus sits right next to the bladder, and in front, this rock-like thing is going to be right on top of her bladder and compress it, causing increased urinary frequency. She's going to wake up at night to urinate. Whereas the ones located maybe laterally are going to press on pelvic nerves to cause pelvic pain, sciatica, back pain.
Wow.
Ones near the cervix causing painful intercourse in the back of the uterus. It's going to cause this low back, buttock pain, maybe painful bowel movements or constipation. So depending on where they're located will determine what symptoms. And so usually it's the symptoms that lead a woman to go, wow, something's not right here. And then they go to the gynecologist, and then the gynecologist will tell them the treatment options based on, they will get an imaging, usually ultrasound, and then confirm the diagnosis and then start some form of treatment.
Wow. Yeah. So everything you are saying is so fascinating, because I know so many women, including myself, who have had so many of those symptoms, who went to their PCP. And I remember my doctor telling me, I was telling her my periods are really heavy. I'm not getting pregnant. She said, that's normal, and you're young, you're healthy. Keep trying. And I knew in my gut something was wrong. Where you're saying you need to be your own health advocate, I knew something was wrong.
Yes.
So what I did, she wouldn't give me a recommendation to see a specialist. So I got my hormones tested at home. I went through this company called Let's Get Checked. And my progesterone was really low. I think my estrogen, it wasn't high, but the progesterone was really low. And there was something else on the test that was a little alarming. And then I gave her my results, and then she gave me the specialist, and then we went through so much. And then finally I found that I had fibroids. But yeah, it's just, why do you think, I found it interesting that you said that African Americans, and I'm sure even Hispanics, minorities in general, have a higher rate of having fibroids. Why is that? What's the difference?
There's a couple of reasons why. One, genetically it runs stronger in African American families, because I see fibroid patients every day in my office, and some will have very low body fat, they're very fit, and they have big fibroids. But the other reason, and that's a genetic kind of run strong in their families, but the other reason has to do with body fat and estrogen. While nobody knows where fibroids come from, once they arrive, they grow with estrogen and to some degree progesterone too, hormones, but primarily estrogen. That's why they can grow pretty rapidly during pregnancy, and why they tend not to be an issue for most women once they reach menopause.
And that's because your hormone levels dip after menopause, your estrogen goes down, correct?
Exactly right. Estrogen is stored in body fat. So if you look racially at body fat distribution, African Americans #1, Asians lowest. That's also, African Americans have the highest fibroid incidence and Asians the lowest. So the genetic aspect, you can't really do anything about that, but everybody can try to be as close to their ideal body weight, lose that excess body fat, because it's not only going to be really good for your fibroid health, it's also going to be good for your cardiovascular health, your overall health. So that's something we emphasize at Atlanta Fibroid Center, is to try to increase a woman's exercise if she's overweight or obese. Try to increase exercise. Try to make better dietary choices. There are hormone-rich foods that, kind of red meat, non-organic chicken, dairy. Try to limit or avoid those, and increase fruits and vegetables, particularly colored vegetables, because colored vegetables have flavonoids in them, they are compounds that block an important enzyme in estrogen synthesis. So again, making healthier eating choices, trying to lose excess body fat. And then vitamin D is really important. Vitamin D, only 10% of African American men or women have adequate vitamin D. And vitamin D is actually not really a vitamin, it's really a hormone.
Mm-hmm.
Exactly. And
Yeah.
it's really important. It's your best anti-fibroid growth hormone that we have. And with only 10% of African Americans with adequate vitamin D, that's another area that we want to make sure that they get adequate vitamin D supplementation if they need it. These things will all help fibroid-related symptoms, and maybe enough such that if your symptoms aren't terrible, with these modifications, you can do just fine, and that's great.
Mm-hmm. Is there any other supplement that you suggest? I know I've done my own research and have used supplements like DIM or I3C, just because, like you were saying, the vegetables, they have certain things in them, a lot of flavonoids and sulforaphane, and they put that in those supplements. So they bind to the estrogen, and I've read that it also helps lower your estrogen. So do you refer or tell your patients to take those type of supplements too?
I don't know. There's anecdotal reports on DIM and some of these other things. There's really good data on green tea extract. I think that's a really good one. I mean, it's been well studied. So green tea extract is a good one. Some of the ones like DIM, and there are some herbal stuff, raspberry tea. Some of the herbal stuff is good if they have low iron. Blackstrap molasses and some of these other things that boost iron that are helpful when they're anemic. But the reason they're anemic is because of their heavy periods, and they can't replace that amount of iron or hemoglobin. So they become anemic, they're weak, they're tired. In fact, the heavy periods and the anemia are usually what cause a woman to try to seek attention from a physician.
So you mentioned earlier, you would get into detail how heavy is too heavy, because, I grew up, my mom had heavy periods. My auntie had heavy periods. Everybody had heavy periods. So it was almost like normal. I didn't think like, oh, this just runs in the family. So
exactly.
How do you know when it's too heavy?
Well, if you're bleeding such that you're changing pads more frequently than every 3 or 4 hours, or you're passing clots, and I'll see patients passing clots much bigger than a quarter, sometimes palm size and fist size clots. I mean, if you're passing clots that are quarter size or bigger, that's too much. Or if you get episodes of blood gushing out or flooding, changing frequently, having to change multiple pads at a time. Certainly, I say more frequently than every 3 or 4 hours is too frequent. Accidents in blood. If you have to sit on newsprint or have to sleep on, rubber sheets, or you're afraid to, soil clothes or linens, accidents in blood, that's just too heavy.
Yeah.
But a lot of women do that all the time.
What about like super tampons? I always had to buy super tampons, super pads. Is that another indication that it's too heavy?
Sounds kind of heavy. I mean, it depends on how often. I mean, if you don't have to change very often, maybe it's okay. But changing frequently and these heavy aspects of the period, to me, if a woman's period, to her, if it interferes with her quality of life in any way, that's too heavy. But a lot of physicians won't treat it unless they are anemic by blood test. They test the hemoglobin level to see if a patient falls in the quote anemic range. But if she's bleeding heavily, to me, it doesn't matter what her hemoglobin is. If she has to carry around an extra bag of clothing, or if she can't sleep on, fine linens, or she's afraid to sleep on her girlfriend's couch. I mean, this interferes with her life. If it interferes with her job, it is too heavy and needs to be treated.
Yeah. What about length? I've heard girls say that they've had their periods for 2 weeks.
Yeah, no.
I was blown away that that didn't ring an alarm
Right.
for them.
Yeah, you might go 7, 8 days, but anything beyond that, that's not normal.
Yeah.
The typical period will run somewhere in the 5 to 7 day range.
Yeah.
But then when you start getting, 8 days and above, that's not normal. Now, as I say, some people do this month after month and they just believe that's their normal. And as you said, well, my mom's a heavy bleeder, I'm a heavy bleeder. No,
Yeah.
your mom had fibroids and probably had a hysterectomy for fibroids and was horribly anemic. And now you're going through the same thing.
Yeah.
They're not realizing, that it's not normal because, people don't want to talk about this. I mean, that's
And
another aspect.
I
They
think
need
this
to
is
share
so,
this.
yeah, I think this is so wonderful that you're on here. Sorry to cut you off, but we need to start having these conversations. And it wasn't until I started having these conversations, and thank God for Google, I started finding other people having these conversations, that I was like, oh, I need to do something about this because I know something is wrong. I think it could be this, but I wasn't sure. For me, they thought it was PCOS. It wasn't. They thought it was other things. And until they actually did a vaginal ultrasound, that is where they found. And I found it so interesting that when my doctor told me the size of my fibroid, she said it was literally like the size of my thumbnail. It was so small, yet it was still causing all this havoc.
Yep.
So do you find that common?
Yes, it's about location. Very, very big fibroids that are the subserosal type, as I mentioned, can be very big and may not press on anything to cause any symptoms. It may make a woman look pregnant, but other than that, she may have no symptoms despite a very big uterus. You take a small fibroid that's submucosal underneath the lining like you had, those small ones can cause really heavy periods. So it's all about the location.
Wow. I am a health coach, nutritionist, and herbalist, and I often coach young kids. And I'm noticing a lot of my girls, 9 years old, 10 years old, are starting to get their periods. And they will tell me they're painful, they're heavy, and I am blown away. What is it that, I know when I was young, we didn't get our periods until we were 14 or 16 or 15. What is it about this new generation that these young girls are getting their periods and it's like with a vengeance?
Well, I think it's hormonally related. You can't avoid the hormones. It's even in the water supply. I mean, with all the people on birth control pills and it's getting, it goes, you excrete it in the urine, it goes into the water supply. So, I mean, there are hormones even in the drinking water. So our kids have gotten exposed to hormones much more so than we ever did. And so young girls are getting their periods at an earlier age. And, there are consequences for that. But fortunately, fibroids usually don't rear their ugly head, if you will, until early 20s at the earliest. Now, we've seen some teenagers, again, African-American women, not only get them earlier in life, they get them bigger and more numerous, and they're more likely to get, operated on, either hysterectomy or myomectomy. So they certainly have, get it disproportionately in all aspects of it more than other racial groups. But this is an important topic for all women because eventually, the majority of women, no matter what race, will encounter fibroids in their life in some form or fashion.
Yeah. Okay. So for my clients that are young with heavy periods, do you think they would be a good candidate to get checked for fibroids, or what can I guide them or help them with at that young of an age?
Well, I think if you know that their moms had fibroids, I think you can start a conversation about the fact that likely they will encounter fibroids too. And the best things that they can do are eating healthy, maintaining whatever their normal weight for their particular frame is. No one's saying they have to be skinny, but everybody has this ideal body weight for their frame, as close as they can be to that, and making healthy eating choices, exercise, And again, the vitamin D level is really important too.
So with the vitamin D, would you say just to go out and buy vitamin D, or is it important to check the levels of your vitamin D so that way you're getting an adequate amount when you supplement?
Yeah, it's really important to check. Unlike vitamin C, which is a water-soluble vitamin, if you can take all the vitamin C you want, whatever your body needs, that your body will use, and the rest you'll pee out. With vitamin D, it's a fat-soluble vitamin, and so you really need to get the levels checked so that you can have too much vitamin D, and that wouldn't be a good thing. So get your vitamin D level checked, and depending on how much you might need, the person taking care of you will tell you kind of how many international units you might need each day to supplement. Usually the pills come in 1,000 units or 2,000 units per capsule, and depending on how many thousand units you need, they will tell you, and that's all you need to do.
Okay, good. That's something I will make sure to pass on to the girls that I coach. I often tell all my women, young, old, no matter, I always say your menstrual cycle is your 5th vital sign. As a woman, it will tell you if something is going on in your body. And I know we just spoke how periods can definitely tell you what's going on with your body. Are there any other signs that maybe we wouldn't think of that may be an indication that you have fibroids?
Well, obviously you can feel these things, when they're toward the front of the uterus. So they feel like hard rocks. It's very palpable when they're in front because the woman is soft and these tumors are hard as rocks. So you can feel them. And so that might bring it to attention. It enlarges the uterus and it starts to make a woman look pregnant. In fact, they can, measure the uterus in terms of a pregnant size uterus. So a woman's uterus full of fibroids up to her belly button, that's a 16-week, 4-month size uterus. And we see that all the time, even bigger than that. So
wow.
Those kinds of things. And she may think, well, I'm getting a little older, I'm not exercising as much. Maybe it's just kind of old age kind of. No, it's not. These are fibroids, and you can see them on imaging very nicely. We use MRI imaging, which is much more sophisticated than ultrasound for a very similar cost. So you get to really see things to great advantage, because a lot of times women will get an ultrasound and they may be told they have 1 or 2 fibroids based on the ultrasound, but we get the MRI and there's 15 or 20 or more. I mean, they're like, where'd they all come from? Well, the MRI can resolve these things much better than an ultrasound. And so it's really the gold standard of imaging is to get this MRI of the pelvis. It's very helpful.
Why do you think doctors are still using vaginal ultrasounds if, the evidence shows getting MRIs are more accurate?
Well, 2 reasons. One, almost every gynecologist has ultrasound in their office, and so it's right there, and so they use it. And it used to be that ultrasound was much less expensive than MRI. It's not the way anymore. They're very comparably priced. So the price differential is really not significant any longer. So there's really less of an excuse to use it. We don't use ultrasound at all. We go right to MRI.
Wow.
It's so valuable. It even can change what you want to do. There are medical conditions that, we see patients. In fact, I saw one last week and see this fairly commonly where a woman was told she had fibroids in her uterus for many years. She didn't have fibroids at all. She had another similar condition called adenomyosis, which causes similar symptoms to fibroids, but is completely different. It's not fibroids at all. And so she was stunned when I showed her the imaging and couldn't believe that for years she was told she had fibroids, but there weren't fibroids. It was adenomyosis. So the MRI is very important.
Can you explain what adenomyosis is?
It's in the family of endometriosis. Endometriosis is when the lining cells, which are called the endometrium, when those lining cells are found completely outside the uterus, that's endometriosis. And they can be around the ovaries, the fallopian tubes, the bladder, can be anywhere, even outside the pelvis, rarely. And they just start bleeding out in the breeze, if you will. They're not inside the uterus. They're completely outside the uterus. It causes a lot of pelvic pain. It causes a lot of infertility. It can wreak havoc in those that are suffering with significant endometriosis. Now, adenomyosis is when those lining cells just plunge deeper into the muscle of the uterus. So by definition, even though it's a similar process, or maybe even identical process, because it's still inside the uterus, they can't call it endometriosis by definition. So they gave it its own name, adenomyosis, but you can, in simple terms, you can think of adenomyosis as endometriosis that involves the uterus.
Wow. Okay. Do women who have endometriosis or adenomyosis or any other PCOS, any things like that, do they have a higher risk of having fibroids because they already have something else going on in the uterine cavity area?
Well, there is an association, and it's really hard to know because fibroids are so common that when you see something else, and we commonly see adenomyosis and fibroids together, so there does seem to be an association, but clearly if you have adenomyosis, you're much more likely to have endometriosis and vice versa because they are in the same family. They're just in essentially two different locations. But there also is a fair number of patients that with endometriosis or adenomyosis that also have fibroids. So in dealing with these patients, you have to really look at, for me, because I can handle anything that happens in the uterus. So fibroids and adenomyosis, I can treat very successfully. Endometriosis, which is completely outside the uterus, I can't help them with. So hopefully the patients I see have little or no endometriosis at all, and everything's going on in the uterus. And if so, uterine fibroid embolization is a tremendous procedure. It's truly one of the biggest medical breakthroughs for women. I would put it up there with the mammogram and the pap smear in terms of significance for women, yet most women that are struggling with fibroids never hear about UFE, and that's a real shame because there are so many women we could help with UFE. There's over 1 million on the sidelines. We call them the silent sufferers. They don't want surgery. They don't want hysterectomy. I don't blame them. I wouldn't want it either. And there's no reason any woman needs hysterectomy if they're suffering with fibroids, no matter what your gynecologist tells you. If there's one thing that I want to emphasize, no matter what your gynecologist says, you do not need a hysterectomy for benign fibroids. Period, end. UFE is likely going to help you.
Yeah, I wish I knew about you and this procedure before I had my surgery. But like you said, not a lot of doctors are disclosing this information to their patients. I mean, my surgery was so quick. It's like I couldn't even wrap my head around, what was going on. It's like, oh, you have this. Okay, surgery here. You're going in next week. And it was just like, I should have, I should have done more research, but I feel like it's my job to educate other people so they don't have to go through the same thing. So I'm so appreciative for you explaining that to everybody. Are there any other things that can help, women with fibroids other than diet and exercise? Or how do you feel about birth control? Does it hurt or does it help? Because I know there's estrogen birth controls.
Right. See,
so I'm assuming.
Well, that's the rub. You hit it right on the head because birth control pills are a double-edged sword. They're often used as a first-line therapy for fibroids because they will often lighten the flow, at least temporarily they will. So they lighten the flow, and in a sense, it buys the gynecologist some time because the gynecologists are surgeons, and surgeons want to operate. And a lot of times they can't operate on women if their hemoglobin or iron is too low. Because the surgery, if the hemoglobin level is a certain level, the normal is 11.7 or thereabouts. When it drifts below 10, they usually won't operate because they know they can't operate if it's 8 or below. So, and there's usually a delay between when they sample to see the hemoglobin level and they do the surgery. So depending on the gynecologist, they won't operate below 10 or certainly below 8. There is no such stipulation with UFE because it's not surgical at all. So I've done UFE on patients with hemoglobins less than 3.
Wow.
Very low hemoglobins. We do a lot of Jehovah's Witnesses. There's no blood loss. We don't have to worry about the hemoglobin. We certainly will try to boost them up, but there's no blood loss, so we don't have to worry about it. But so the birth control buys them time that lighten the flow so that maybe their hemoglobin will rise to a level where they can operate. The problem is, as you mentioned, birth control pills have estrogen in them, and estrogen grows fibroids. So while a woman is on birth control, she might experience lighter periods for a while, but in the background, it's like pouring gas on a fire. These fibroids are growing more rapidly than they normally would, and eventually this growth overwhelms the ability for the birth control pills to work any longer, and then they go, okay, this isn't working, now let's go to the surgery. And they don't mention UFE, which really they're obligated to mention, but unfortunately most don't mention it.
Wow. Okay, so what about the woman who, let's say she goes through your procedure, she gets her fibroids removed, and now,
Don't remove them now. We don't do any surgery, no removal.
Sorry.
Maybe I should explain the UFE.
Yes, explain that. How about that?
Right, so the approach is at the top of the right leg or the left wrist. We prefer the top of the right leg approach because it's closer and the vessel we're entering is much bigger than the artery in the wrist, but you could do either approach. It's called a right common femoral approach. And so we use local anesthetic and numb the skin, and that's our entry point into the body. There's a uterine artery on each side of the uterus, a left and a right, and we can, one at a time, just negotiate a little tiny catheter. It's like a piece of spaghetti into each uterine artery, one at a time. Each uterine artery branches like a tree. There's a big trunk, and then they get branches, get smaller and smaller and smaller to get out to the leaves. The fibroids are the leaves of the tree. And I know what size those tiny peripheral branches are, and I can flow direct particles to plug up those branches. Without a blood supply, the fibroids die instantly. Over time, the death causes the fibroids to soften and shrink. And as they soften and shrink, a woman's symptoms go away.
Wow.
So it's a 30-minute procedure. We put a Band-Aid where we go in at the top of the right leg when we're done. There's a several-hour recovery at our center. So they come in the morning, 30-minute procedure, recover for several hours, leave with a Band-Aid, and a recovery at home, usually around 5 days. And importantly, they get to keep all of their parts. They don't lose their uterus.
Wow, that is amazing that you can do that with a catheter and not have to. I did try to do a little research, and I saw there's some that they have to go through your stomach, but you're still making incisions and going in. This is amazing that you don't have to go, vaginally. You don't have to go through the stomach.
No vaginally, no surgery, no cutting on you, no robot. You hear all sorts of things. Oh, I'm getting robotic surgery.
Yeah, that's what I saw.
You don't need a robot. You don't need a hospital. This is done in our office at the Atlanta Fibroid Center. So no hospital. So you're not going to encounter any COVID positive patients in the building.
Yeah.
You can pull right up to the front door. It's very convenient. You get your own private nurse throughout the experience. It's just a great environment for patients, and it's a great procedure. And it's something that everybody should know about. And so if you're suffering with fibroids, everyone needs to know about UFE. It's a tremendous underutilized procedure that really, I call it the triple crown. They get the relief of symptoms, a very high success rate. So that's great because that's why they come to see us. Secondly, they avoid the risks and long recovery of an operation. That's great. And third, they get to keep their uterus, not lose it, because we haven't talked about what happens to women when they lose their uterus. I commonly see women every day whose gynecologist told them, oh, you're 40, you're not interested in kids, get that uterus out. You don't need that uterus anymore. Yeah. Or even younger. The average age of hysterectomy in this country is 39. And we've seen way too many women less than 30 already have had a hysterectomy. It's tragic. Yeah. Never, ever, ever need a hysterectomy for fibroids. Let's stop doing that. It's why are we amputating? Essentially, hysterectomy is an amputation. Why are we amputating young, primarily African-American women for benign disease? This is not cancer.
Yeah. Wow. Yeah, like I was saying earlier, they wanted to take my uterus, and I was like, no, there's got to be another way. So would UFE be available for all fibroids, like even
All
certain
fibroids.
locations?
Doesn't matter how big, how many, where they're located.
Okay.
Treats them all, which is, again, another benefit over myomectomy. When basically the gynecologists have two procedures, myomectomy or hysterectomy, and that depends on a woman's desire for fertility. If she's not interested in having children, as I mentioned, she gets hysterectomy. If she's interested in fertility, either possibly or definitely, she'll be offered myomectomy. The problem with myomectomy is a number of things, but the Achilles heel for myomectomy is they can't remove them all.
Yep.
That's the Achilles heel. And so a woman undergoes this big time operation. A myomectomy is much harder than a hysterectomy. Hysterectomy is amputation, clamp, cut it out. Myomectomy, they have to carefully try to get these fibroids out of the uterus and have an intact organ when they're done. And that's the other problem. Some of the women wake up without their uterus because they get into too much bleeding and they can't reconstruct the uterus. It's very difficult. And so a lot of women that have successful myomectomies have living fibroids in their uterus, which in a typically 11% chance per year will need another procedure. So 11% of myomectomy patients within a year need another procedure, over half within 5 years.
Wow.
I saw a woman today had already had 3 myomectomies and she was coming to see me. It's crazy. One myomectomy, okay, one myomectomy, but if the second procedure should always be UFE after that.
Yeah, wow.
Because you keep setting yourself up for more procedures. I mean, why are we doing that?
Yeah. So with UFE, it will prevent any more fibroids from growing, or do you still have to change your diet and your lifestyle?
Yeah, I mean, it's still good to do those practices just because it's good for your overall cardiovascular health. For the vast majority of women over 40 that are embolized, for the vast majority of them, it's a one and done. So by the time they could ever grow new fibroids that would amount to anything clinically, they'll be in menopause. So if you're in your 40s and you get a UFE, typically, not every single case, but the vast majority, it'll be a one and done. Now, if you're less than 40, you have more of a chance of at some point, and we've done that. It's not very common. We've done a second embolization on some people. That's fine. I would still say 2 UFEs.
They're better than a myomectomy.
Way better than one surgery.
Yeah. No, I can definitely understand that. Wow. So tell me, how does your practice work? Do you have to have health insurance? Or do you take all health insurance? Do you have a waiting list, or are you accepting patients right now?
We see patients from all over, not only all over Atlanta, all over Georgia, the Southeast, outside of the Southeast, even outside the US. But we take every insurance, all insurances, including Medicare and Medicaid. A lot of specialists don't take Medicaid. I think that's wrong. I think it's kind of a responsibility of ours to accept Medicaid. And so all insurances cover UFE. So if you have some form of insurance, that's really good. Now, there are some people that don't have insurance of any kind. That's harder to treat those patients because the procedure is costly. We do have a relationship with Good Samaritan here in Atlanta, where we help some people that literally don't have any means. And so we do what we can, but it's certainly best if you have some form of insurance.
Okay. Have you ever seen any patients who, on their own from lifestyle change, shrunk their fibroids, or they've disappeared on their own?
Yes, you can. And if you're really diligent about it, I've seen some patients that are really diligent about, what they're eating. They've converted, say, to a vegan lifestyle. They're very low body fat, exercising, eating well. Yes, you can really take care of your fibroid symptoms either significantly or in some cases entirely, and not need anything else. And that's what we emphasize at the start, because it's always best to be on the front end of things and the preventive.
Yeah.
I'm like the mechanic for a broken down car, because when the patients come to me, they're usually at a point where they can't, their car's broken, they need it fixed.
Yeah.
But we emphasize the, preventive stuff. Put the right fuel in your car, do the preventive maintenance stuff, keep your car up and, keep it running, right, with the right fuel and the right care and maintenance. You might not have to see the mechanic.
Wow. Yeah. I actually, after my surgery, I ended up doing more research, because after my surgery, they tested the fibroid, or they found a cyst, and it came back precancerous for uterine cancer. So then I had to go see an oncologist, and that's when they were really pushing, we want to take your uterus out. And I ended up going vegan, and I told them, give me a couple months. I thought I was healthy. I was active, but I completely removed dairy and animal products, because I knew already that could make the estrogen related cancer grow more. And they did 2 biopsies on me 3 months apart, and they couldn't find anything. So now I'm in the clear, but I now know. Yeah. And I read the book. I don't know if you've ever heard of it, The China Study.
No.
But he talked about he fed different groups of mice IGF-1, or just like, animal protein, and they would grow cancer. And then when they gave them a vegan diet, and it would make the cancer tumors, revert. So, but yeah, so I love that you're a physician who is actually an advocate for lifestyle change and eating healthy and being on the preventative side. So that's like music to my ears, because I've seen how much it's worked for me. And I remember talking to my oncologist about it, and she was like, that's not going to work, basically. And I said, just give me time.
Yeah, it does.
And she also wanted to put me on a birth control that was progesterone only, like the Mirena IUD. How do you feel about those type of birth controls that are only progesterone?
Well, I mean, Mirena is a common thing that's, it's a progestin-laden IUD that does lighten flow again, but even the progesterone family of hormones does stimulate fibroid growth. So it's not just estrogen, progesterone too. So for the same reasons, it's kind of this double-edged sword. Mirena will work for a while, but eventually, usually it gets overwhelmed by the growth of these fibroids. So,
wow.
But you brought up a number of really good points about, trust your gut. I think that's really important. You knew that when something wasn't right, it's not right. When you have a certain belief in something that you think will work, trust your instinct and your gut on this. You're likely to be right. Certainly, if you go to a physician or any healthcare provider and you feel like you're being dismissed or you're not being listened to, leave. Find another doctor. There are plenty of good doctors out there. You need to find someone that's going to be your partner in this. It's not I'm the doctor, you're the patient, this paternalistic kind of, we're in a team together. And that's why it's important to prepare to see the physician, be armed with questions, bring somebody with you. That's really important, because, when I tell
sometimes
patients,
you're emotional and you don't take it all in.
I saw that patient that I told you earlier that she thought she had fibroids and she had adenomyosis. And when I told her she didn't have fibroids, everything after that was like, she was still coming back to that. She still couldn't grasp anything. She couldn't grasp anything after that. It's like, you're told cancer. As soon as the word cancer, you just, that's it. Everything is.
You don't hear anything else.
You don't hear a thing. So come with somebody, bring somebody with you, so that person can help you kind of, remember the things you need to. And then, if you're being dismissed or not listened to, find another doctor. There are plenty of good doctors out there. And you're part of a team. They're there to help you. So come with your questions. I say, I don't have specific times where I see patients. I have my own practice, so I'm not under the scrutiny of a hospital.
Of having so many patients
Right,
come
like
in and out. Yeah.
like on a hamster wheel.
Mhm.
You know, the patients, my new patient consults are usually 45 minutes, maybe even an hour, because we'll go until their questions are all answered. And
Wow.
I can't believe it. I mean, when I see my doctor, I'm lucky if I get 3 minutes with the physician,
Yeah.
5 on, you know, if I have a specific issue we're talking about. But that 5 minutes is like the max.
Wow.
But as I say, everybody, they can't believe it. They're like, wow, you answered everything. I'm like, yeah, because that's how we know we're done. There's no
Yeah.
time limit here. We're here until we get everything answered.
Oh, that is beautiful. Wow, that's amazing. All your patients are so lucky to have a doctor like you. Being that we talked about, you know, lifestyle change and food, how do you feel as a physician? Most physicians I talk to, they say that they didn't get much education on nutrition. How do you feel about it since you're an advocate for it?
It's sorely lacking. There's no question about it. But I think it's changing. There's been more and more emphasis now. In fact, I interview medical students for one of the medical schools here in Atlanta, and you know, we talk about, you know, getting more of that into the curriculum. It's really important. We're doing a number of different things. We want medical students to be more well-rounded before they come in. They don't have to be, you know, they have to have a good core of math and science, but they don't have to be just so, you know, in my day, everybody that went into medical school, they were pre-med bio majors, pre-med bio. That was pretty much it. Now, you know, you can have history majors and philosophy. They got to do the math and science, you know, curricula to get into medical school. You have to have a certain math and science IQ, if you will, and pass those sections. But you don't have to be so narrow focused. Same with, you know, the nutritional stuff and all the preventative stuff is really important. So there's more and more of an emphasis now than there's ever been, and that's good. We need more on that side.
Yeah. I took, after my cancer scare this summer, I was reading a bunch of books, and I took this online class. It was called Cancer and Nutrition. It was by 3 doctors from Japan, and it was mind blowing. I was just like, wow, like, I'm not a doctor, I'm just a nutritionist, but even the studying that I did to become a nutritionist, I didn't learn this type of nutrition that they were teaching. And that also aided me into becoming a vegan and changing my lifestyle. But yeah, I'm so on board with you that, you know, there needs to be, and I think for everybody, because we all, like you said, need to be our own advocates. We can't just depend on medical professionals to, you know, have our best interest or know what's best for us. And I think, you know, if you care about your health, you should know how to be your best health, to be at your best health.
Yeah, I mean, and get that second opinion. And any doctor that gets upset with you getting a second opinion, that's another red flag.
Yeah.
I have patients all the time saying, wow, that UFE sounds amazing. It almost sounds too good to be true, but I think I need to ask somebody about that, and by all means. But a lot of gynecologists will downplay UFE because they're surgeons. They want to operate, but interventional radiologists, if you want to get another opinion from another interventional radiologist, you'll see that likely they'll say the same thing, that UFE, almost every patient that has been told they need surgery can be done with UFE. I mean, there are rare exceptions. Certainly every patient that's been told they need hysterectomy can be replaced with UFE. And a number of the myomectomy patients, it's a little more of a longer discussion when you're doing UFE versus myomectomy, just because fertility is involved. And I've had numerous children born to patients that have had UFE with us, lots of children, quite a few sets of twins even.
Wow.
And the births that we see in our patients after they've had UFE and they're delivering children, our births are typically full term and vaginal.
Wow.
Whereas if you have a myomectomy, they won't let you have a vaginal birth. It'll be a C-section, more surgery.
Wow. I didn't know that. Wow.
Yeah.
And
Yeah, in
that's the
fact,
thing, they don't tell you these things. They don't tell you about birth control, the
yep.
side effects. They don't tell you, when you have a myomectomy, that that's a side effect of it when you do have kids. So, wow, this is even eye-opening. And I thought I did all my research. I'm still learning stuff. So,
Yeah, I mean, hysterectomy, number one, hysterectomy is the second most common surgery done in the United States. C-section is number one. And the most common reason why we do hysterectomy is not for cancer, which would be appropriate. It's for these benign fibroids. And the average age is less than 40. So again, why are we doing all this surgery on young women when we don't have to? It's for benign disease. There's no reason to be doing all this surgery. And it could be replaced with a non-surgical outpatient procedure where they go home with a Band-Aid.
yeah.
Hysterectomy has consequences for women. As I said, I heard, all the time, the gynecologist, you're done having your kids, just take your uterus out. Well, I'll have patients say, yeah, I'm done having children. I'm just not done with my uterus. Thank you. I'd like to keep it. And they should, because, if you look in the aisle where there's, the adult diaper section of any, pharmacy or any, Kroger, Publix, whatever your big shopping grocery store is, they have a health aisle. You go where the adult diapers are.
Incontinence, right?
And you pick up the package of Depends. Likely you'll see an attractive young African-American on the package.
Wow.
Now, why is that? Well, the Depends is a big company. They have Madison Avenue marketers there. I think they're, I'm not sure if they're P&G or one of the big companies. So they're not dumb. They know exactly who their target is. Their target is young African-American women that have had hysterectomies. Now they're leaking urine and they need to wear a diaper. You've taken this big fibroid-filled uterus out of their pelvis and their pelvic floor muscles are weak and they leak urine. Well, I mean, that's crazy. I mean, we don't need to do that.
And they don't tell you that again. They're not going to tell you, okay, we're going to take your uterus out, but you're going to be having incontinence. I've trained so many women who would tell me, please don't make me jump. I've had a hysterectomy and I don't want to go to the bathroom on myself, Yeah,
and there's a lot of bone loss after hysterectomy. There's a lot of sexual dysfunction.
Yeah.
If you go into Google and you type in hysterectomy sexual side effects, you'll see this tsunami of stuff about people never told me, loss of libido, loss of orgasm. Tragic, because these are young women. Again, these are often women in their 30s, sometimes even in their 20s. There's just no reason to be doing this. We got to put a stop to it.
Yeah, I had a client recently. She was in her 30s and she was engaged and she had heavy periods. I'm not sure if she had fibroids, probably. But she had a hysterectomy and my heart just broke. I just wish that I would have gotten to her earlier,
Yeah, it's really sad. Whenever we go to events, I speak all over the country on this. Invariably, after my talk, someone will come up afterwards and they're like deer in the headlights. They can't believe that, they may have seen even multiple physicians, all of whom told they had to have a hysterectomy for benign fibroids, and they didn't. And they're like, I never would have agreed to this, but no one ever told me. And that's why educating yourself, being your own health advocate, if something's not right in your gut, there's something not right. You gotta be at peace with whatever you decide to do, but arm yourself with as much information as possible. Not only, about fibroids, but whatever health condition, information is power.
Yes, it is. And I love that you are out there spreading this information and, saving so many women from, lifelong of, medical issues or other things that could happen when they get a hysterectomy or different types of surgeries.
It's transformational. I mean, if you go on our website or you go on our Instagram page, you'll see numerous testimonials. I mean, women have been struggling with horrific periods. I mean, fist-sized clots, gushing of blood flowing down their legs. I mean, just, crime scene-like periods month after month, accidents in blood and having to leave work, miss work, put their relations with their boyfriend or husband or whoever on hold, social activities on hold, can't go swimming, can't go vacationing, can't work. Everything revolves around this darn period, and it's month after month. So not only is it physically draining from the anemia and the weakness, the lethargy.
That wraps up this week's episode of the Fit With Fallon podcast with Dr. Lipman. If you are interested in a non-surgical procedure to treat your fibroids like UFE, you can head over to the Atlanta Fibroid Center's website, which is atlii.com, or go to Dr. Lipman's Instagram at Dr. Lipman on IG for more information. Make sure to check us out next time, same place, same channel. Take care. Have a happy and healthy week.